My name is Drew Woods. I'm the co-chair of the Education Committee on the AOC PMR's Resident Council. I'm excited to start this new programming, which we've dubbed the Freeway to Fellowship. If you have a better name for that, feel free to make a recommendation. But with this, we're hoping to explore kind of the various fellowships available to PM&R residents. Our hope is that through these virtual conversations, we'll be able to help you navigate your own process and get you to the fellowship of your dreams. So it's my privilege today to be joined by Dr. Jamie Key. She's the program director for the University of Kentucky's PM&R program, as well as their new Brain Injury Medicine Fellowship program, which will be welcoming its first fellow in 2023. So Dr. Key completed her residency at the University of Kentucky in 2016, and after spending a year in private practice, came back to Lexington to serve as the associate program director and then the program director. And so in addition to these roles, Dr. Key has a true passion for resident and physician wellness and has recently been named an ambassador for diversity, equity, and inclusion with the University of Kentucky College of Medicine. So Dr. Key, it's great to have you. Thanks for joining us. And I'd love to start by kind of asking you about your own journey to brain injury medicine, kind of what drew you to it, and kind of give us your backstory.
Yeah, it's a pleasure to be here. I'm very familiar with a lot of the AOC PM&R community, and it's always a fun time to give back to that group and hope that I meet a whole new gamut of you all this year as we start the new recruitment cycle for not just residency, but also the fellowship. So I've been interested in brain injury and neurological processes in the body since I can remember, probably. I always gravitated towards that in medical school. And what most of you don't know about me is I dual applied. Don't do that. Don't ever tell your PD you did that. But I dual applied. I did PM&R and neurology because back then I didn't know which one fit what I wanted to do better. And then the more that I rotated in PM&R, I realized that I was going to make way more of an impact with that type of patient population than I ever would being a neurologist. But hold on. So I went through intern year and drank the Kool-Aid enough in neurology to almost switch out of residency. I was also one of those. I am the epitome of what not to be after being PD for a while. But I almost switched out and switched to neurology. And saw the light again before I could get out of that bad situation, and remained in PM&R, which I can't even imagine what my life would have been like. I probably would have stopped being a doctor at this point or gone back to residency or something. But I've always loved the neuro patients. It's where my passion lies. Even before I knew I would do this, I wanted to do some kind of charitable work with that patient population. And so it just made sense. And so I did. I went to Cincinnati for a general practice, private practice gig. It was fine. Like I've told Drew many times before, I got a little bored and I missed teaching. And there's a sense of renewal that you don't get every July, even after you've come in as a faculty member and don't actually progress. You feel the progression every July. So I needed that. Just like a dream, I was offered the brain injury spot at UK. It just happened to open up. And so I came right back home. And everything is manifested after that. I've never had one idea or another about how this was going to unfold, but it has done so seamlessly, which is really cool. It's cool to be a part of, especially as our program has grown quite a bit over the years.
Muted myself. So, full disclosure, I rotated with you as a fourth year student, and I spent 2 weeks with you on the brain injury unit. And two of the most impactful patients that I had with you, we'll call them Jim and Caleb, just for clarity's sake. But Jim was a crusty old man that was angry to be there. And it was really cool to see him. He didn't have a disorder of consciousness or anything, but kind of his personality reemerged after his brain injury. And he became really our best patient. And he was almost working himself too hard to the point where he was so motivated just to get back to himself. And with Caleb, I kind of picked him up later on in his progression. He was getting ready to go home by the time that I had picked him up. But even in those 2 weeks, seeing him continue to progress and really, again, kind of remember a lot of who he was and get back his independence. Are there any cases that stand out to you along your journey that kind of either in your medical school or in residency that directed you towards brain injury medicine over something like spinal cord or any of the other, incredible options that are available to PM&R residents?
Yeah, so it started pretty early in my life. Actually, I don't know how many people know this about me, but my brother died in a pretty severe car wreck, polytrauma. He had a pretty major spinal cord injury, and and my dad also died of a systemic neurologic complication. But those things sparked myself to move forward and wonder why we broke the way we did. And so I thought very early that I would do something neurologically, even though I knew for a long time I wanted to be a doctor. But it wasn't until med school and later in med school that I found my first rehab unit. Back then, PM&R wasn't that well known, especially to a DO, right? And so I was doing the internal medicine consults on the rehab unit. It wasn't even a PM&R rotation. And I fell in love with the stroke patients and some of the hip patients, but fell in love with the stroke patients and found myself, wanting to be on that unit even when I wasn't actively working and coaching them along and being there next to them. So I saw the physiatrist walk through the unit one day and I was like, who are you and how do I get your job? And that's how I found out about PM&R. And that was Dr. Paul Jett. He's still kind of actively mentoring a lot of you, I think. So he was my first taste of PM&R, for better or worse. But I quickly found out about UK's PM&R program and did a rotation here as a med student. And I was home and nothing ever changed that after that. I did rotate at other places, but I found this home very quickly and decided this was the place for me. So in residency, I always loved my brain injury rotations. I loved the stroke unit. I also drank all the Kool-Aid, though. I flirted with an amputee fellowship. You're all going to do it, right? You're all coming in wanting sports medicine, but you're going to drink the Kool-Aid. But I was going to do an amputee fellowship in Washington. I was going to do only MSK, right? That's what I left to do. But it really was the neurologic patients that always seemed to fulfill my need for, changing the lay of the land. So it wasn't just a couple of cases. There were cases of disorders of consciousness pediatric patients that came in a coma and they walked out. There's a lot of those. And it's unbelievable to see the phases of every aspect of that patient recovering, to be able to sit and cry with them when they leave the rehab unit and they walk out. But there are patients that don't do well, and I still have every funeral card, the obituary or funeral card of the most impactful patients that I've had that didn't do well, and I keep in touch with their families, and even those made me want to be better at my job, right, in case we can change the outlook for somebody else. So it wasn't just one case, but I didn't say that I majored in psychology in undergrad, and I thought that would be something I would be interested in. And the more I got into that, the more I realized that psychiatric disease, while it is a needed field, I got very frustrated quickly with the fact that it's hard to treat those patients. With brain injury, I still get a taste of that, but these patients get better and they progress, and they transform out of their injuries, but you still get to play with the meds. And so as Drew was saying, and he's Dr. Drew now, as Drew was saying, we have some patients that are angry to be around, and those are actually my favorite. So I'm probably one of the only faculty members that will walk around the unit on call and hear a patient yelling out down the way, and I'll be like, oh, please God, be ours. Because it's a challenge, right? It's a challenge to wake them up, but then it's a challenge to lower their agitation so that they can recover. And it's a game. You have to just kind of do it long enough to be good at it. And that's why the fellowship came to fruition, is because we have a giant rehab unit full of brain injury patients, and we tend to do a good job with them.
Yeah, it's I feel like I know you pretty well, and I did not know that backstory about you and what brought you to it. So thank you for sharing that. That's incredible to hear. And Dr. Jett is a legend with my medical students, so it's funny that he's still training students to this day.
You got a shout out. He still calls me about students every now and then, and he stays pretty close. So he's a good one if you're in our area.
Yeah, he's great. All right, so enough about you, but you've been the PM&R program director at UK for a couple of years now, and now you've created this brain injury medicine fellowship. Why did you decide to drive this new initiative, and what are you hoping to accomplish in these first couple of years, as a new program?
Actually, the goal to start a fellowship started way before I became PD. It started the second I walked back in and started on the brain injury unit. When I came back, I was the medical director of our unit. And that was the goal for this program, was to start a fellowship. But then, I started doing the job of PD way before I had it. I really wanted to be involved with the students or not, well, the students, but also the residents, and got named PD quickly after that. But the the brain injury fellowship has always been in the works, and it's a 2-year process. So us being able to accept a fellowship this year, we could have done outside of the match, started 2 years ago. We were working on this paperwork in effort to be able to have somebody July 2022, which we didn't match anybody for various reasons. And so we'll try formally for next year. So our first fellow should start July 2023 using the ARIS application, which I think we're going to talk about. But it's always been in the works, and just happens to be that we have enough core faculty that are brain injury board certified or sports certified for those in concussion, that we were able to work on both while I've been taking on the PD job.
Yeah, I can certainly speak firsthand to how busy that TBI unit is. And for those of you who don't, I live in Lexington right now. For those of you who've never been to Lexington, Chandler has the highest acuity in the country. And when it's summertime, people love to go out on their boats and ATVs and jet skis, which are prime candidates to come and see you afterwards. So I'm sure your fellows will be quite busy as they get started. So are physiatrists required to complete a brain injury fellowship in order to specialize in brain injury medicine, or are there ways to get around that? And what do you think are some of the benefits of completing that fellowship year?
Yeah, so you don't have to have the fellowship to focus on one population of physiatry or another. Neurologists, psychiatrists, and physiatrists can all do brain injury medicine if they want. Up until 2022, you could take the subspecialty brain injury medicine board exam by grandfathering in. And so if you had enough experience and letter of recommendation, you could sit for the boards. And that's actually how I did it. I worked long enough that I could qualify to sit for the boards. After 2022, though, you have to have had a fellowship, accredited fellowship to sit for boards. And it has to be accredited for you to be able to do that. But, you don't have to have it. If you don't care about having the board certification under your name, then you can definitely serve this population and they'll be greater for it. But if you do ever aspire to work in a larger city or a bigger institution, and if you ever want to lead a program like this or be the medical director, then typically you do have to have that board certification under your belt.
Great. And then I guess, could you speak to kind of what the differences are between an ACGME accredited versus a non-accredited fellowship? And at the end of the day, does it really matter? Will that have any sort of impact on your future career opportunities?
And it might, for the same reasons that I just mentioned. So ACGME accreditation is voluntary. So if somebody says they went into some private area and did, a private non-accredited fellowship, doesn't mean it's not worthy of completing, or doesn't mean that person's going to be any less. It just means that that program did not ACGME certify for one thing, one way or another, probably because they never want to fill out the unbelievable amount of paperwork that it takes to do that, or the annual paperwork that you have to do to remain accredited. There are a lot of program requirements that you must meet to stay accredited, and it's a lot of work. So people opt for one reason or another not to. But you cannot sit for the boards if you don't do an accredited fellowship. And it could be ACGME accredited fellowship. It can be the ACGME International accredited residency. But in order to sit for the boards, at least through ABPMNR, which is what we care about, you have to have an accredited fellowship behind you.
Great. Thanks for detailing that difference. And I guess for these next couple of questions, we'll play make-believe a little bit. So I just graduated, so I'm, I guess, I don't know if I'm technically PGY1 until July 1st, but we'll just say that I'm a newly minted PGY2, and I've decided, I've completed my intern year. I'm looking forward to my PMNR training starting, and I think that I want to pursue brain injury medicine. What tips would you have for me over the next 3 years to kind of best position myself to be a competitive applicant when the fellowship applications open up?
You can go ahead and call yourself PGY1, but I would just say enjoy the next month of your life before you have to own that. But you want to do just like you did for med school, right? You think you're done. You think you've made it, but you've just started. So do just like you did for med school. You know, pretty early on for most of you that you wanted to do one specialty or another. What did you do? You found mentors. You aligned with a program that you liked. You aligned with people doing that same job. You did research and volunteer work in the same field if you could, or at least something that would be meaningful to applying to that certain specialty. And so you have to do the same thing. If you learn you want to do pain medicine, then you align yourself with those mentors and those rotations and that research to do that. It's the same for brain injury. And if you don't know who to align with, then you reach out to someone like me who can put you in the hands of, you know, whoever's going to serve you best. Find a home program that's near you that has a brain injury fellowship or at least a strong brain injury showing, and talk to that program director. And if it's yours, then talk to them about, you know, what it looks like to have a mentor that puts you in line for that. Or maybe you find mentors outside of your institution of residency. Some institutions still allow you to do away rotations. And so you could come and rotate with us or similar programs. A lot of them are getting away from that just due to institutional funding. They have to start sharing and transferring, and it gets really messy. But a program that doesn't offer something similar to what you want to do often will go to bat for you in that regard. They will try to send you to where you're hoping to go. So that's an option too. But if you ever think that you're going to want to do a fellowship in brain injury, then contact someone like me, and then we can get you in the hands of some residents that are similar. Some older fellows, and then me. We have a few residents that have gone over the years to brain injury fellowship, and so our alumni is very great about wanting to mentor and give back to the programs and residencies that serve them. So we have that option too.
I'll use this opportunity to plug the AOC PM&R's mentorship opportunities. We are really trying to expand our mentorship capabilities as much as possible. And we have lots of attendings and residents that are, and fellows that are all willing to give back. And a lot of them come from the UK cloth. So I can definitely vouch for that program to always be there for mentorship. So, you know, it's great to hear that it's just like medical school all over again. You know, you hope that it's the wheel is done turning, but it just starts another revolution. So part of that revolution is the application and interview process. So can you describe, you know, now I guess, can you describe when the applications are for brain injury medicine? I know some fellowships are earlier, some are later. So, you know, when that is, and then also kind of what the process looks like, if it, you know, is identical to what residency applications and interviews are like, or if there's any differences, and, you know, talk about the competitiveness of the brain injury medicine fellowship versus maybe some of the other fellowships that are either more or less known among PM&R applicants.
Yeah, absolutely. So there's you actually still use the same program that you use to apply to residency through ARIS in the AAMC website. So there are 2 application cycles for all fellowships, or for most of them. Through ARIS, there's a July cycle and a December cycle. Brain injury actually occurs, the application cycle opens around August, August. You'll probably be interviewing October through November, and then finish up in December with a match day in December. So if you're going into brain injury fellowship, you find out around December where you're going to go, and you can kind of coast through your 4th year and enjoy the moments. But the difference is for brain injury, we take ACGME accredited or the ACGME accredited programs, but we will take a neurology resident, a psych resident, or or PM&R resident. Any of those can apply to our program. It's kind of the same as with anesthesia pain, right? The anesthesiology residents and the PM&R residents can apply to those, same with some of the sports stuff. So you just have to know which you can and cannot apply for given what residency you went through. But it's an open field more than you think. But it is the later cycle. If you're doing sports and pain, you know where you're going by October, usually in December. So it's really nice to be able to go through that process. But once you apply, it's very similar to before. You've got to get your letters of recommendation. You'll do a personal statement. You'll fill out the entire ARIS application and go through submissions like that. with the difference being that preference signaling is coming for all of PM&R in general this upcoming cycle, which will be nice. Brain injury medicine didn't used to be so popular because you could grandfather in and take the boards, right? We've always felt like we gave such a good experience during residency that you shouldn't need the fellowship year. And, that's kind of held up true given we just graduated someone and they went and did brain injury fellowship this past year and they felt a little bored. So, but now that person had to go through the year to be able to take the exam. And with that, brain injury medicine has gotten a little more competitive because you have to have the fellowship in order to progress in that way. So I feel that it will stay that way now that you have to have that.
As we are applying to residency and talking to programs, and we often hear that, the pain field, we're competing with anesthesia and there's more anesthesia dominated programs. And so PM&R, you still have a shot, but it's an uphill climb. Sports medicine, a lot of them are run by family medicine departments. And so again, PM&R with brain injury, is it kind of the reverse with that, where as PM&R, we might have an upper hand over a neurology or a psych resident just because we get that exposure?
Yeah, I can't speak for all programs. If you've got a stellar applicant one way or another, then you want to give them the chance. But, our program in particular is built around a PM&R residency. And so it would fit the mold to have a PM&R resident in. But if you've got some kind of candidate that just blows it out of the water, it doesn't mean that we wouldn't bring those people in either. You can bring in someone that doesn't fit that criteria, just as I said it, but you have to write a letter to ACGME about why they are such a great candidate outside of the original criteria. But you can bring somebody in that doesn't fit the mold.
Awesome. So back to make believe land. We applied to the UK Brain Injury Medicine Fellowship. You loved us. You said, I want that fellow when we matched to UK's program. What does that year look like? What type of rotations are the fellow completing? What's the balance of inpatient to outpatient? Is research required? Kind of describe what that fellowship year looks like.
Yeah, well, first of all, it's going to be the best year of your life, hands down. Working with me or Dr. Porter all day can't get better than that. So, but you will. It has a different feel to it, and it's not as surgery-esque as like anesthesia pain probably feels, or your ortho sports experiences. You've already finished PM&R residency, and so what you're here for is the experience and not necessarily the beat down that residency probably gives you. So you're an extra body throughout the year. There's never a service that you're on that's completely yours outside of having a continuity clinic, because all fellows need that. They need to start doing some independent practice too to get ready for being an attending. But per guidelines, you need 6 months of inpatient. So they would spend about 6 months on the unit with the team. We haven't decided if we would give them their own patients and I would oversee that, or if they would just be part of the bigger resident and attending team. It could look both ways, but we haven't officially decided on that part. But after that, the rest of the year is pretty fluid as to whether you do some time with neuropsych, neurosurgery, neuroradiology, psychiatry. We definitely want you to do some psychiatry, just given how much it's used. Inpatient consults, and then the outpatient clinic. Outpatient clinic would be throughout the year just because it is a continuity clinic. But it would be a pretty nice year. It's not meant to be one that you feel weary after. It's meant to enhance what you already know and to get you ready for boards. With that, though, you would still have didactics and journal clubs. We would give you all the books and study materials you need on the way in. It's just kind of our motto. If we expect you to use it, we don't want you to have to break trying to get it. So we would give you the Q bank to study for boards and the board review book and all that. I know that you had wanted to know the stipend when we talked earlier. Stipend for PGY5 at UK right now is $67,000, and that tends to increase annually and has done so over the last few years just to keep up with the competitiveness of all programs around. But if you ever want that data, you can find that from any program online. They should be listing their stipends for any residency or fellowship year. And you would be looking at the PGY5 or PGY4 year, depending on what fellowship you're looking at and which program you come from.
Awesome. Not to forget the great UK benefits like the 401k match and everything.
Oh yeah, what am I doing? I'm not on my game. Yeah, you get all the insurance of the land and retirement benefits for coming through. So that's something really cool that we implemented for our residents about a year ago now, or a little over a year, that they can opt into the retirement plans and have matching for retirement, which is really nice.
Yeah, awesome. So we finished the year. You and Dr. Porter, we've had lots of laughs and lots of great patients, and we've learned a lot. But now we're ready to enter the cold world of physician employment and being an adult finally, I guess. So what do those future career opportunities look like after completing the fellowship? Where do a lot of kind of brain injury fellowship trained doctors go to practice? Are they medical directors? Are they program directors? Kind of where do they scatter to after fellowship is over? And I think most important to every resident is, obviously it varies by region, but what does compensation and benefits look like for a brain injury specialist?
Yeah, well, you became an adult when you had your daughter, so welcome. But it's not such a cold world. I don't want to give that message. Once you become a physician and you're finished with your training, you're highly marketable, and don't let anyone tell you that differently. You get to kind of lay the land of how you want your life to go. And if you feel differently when you're applying for jobs, just call me and I'll help you through it. You are the boss in that regard when you're negotiating contracts. But so you've just finished brain injury fellowship. You're about to sit for your boards. Most places that are larger institutions, larger cities, they want a board certified person, and you can come in board eligible, right? You don't have to be board certified to get your first job, because the board exam isn't until September of that following year. So you'll come in board eligible, and most contracts will have that you must pass within a certain number of years before they would, move you along. But if you ever do want to be a director of any kind of program, as I said, any kind of medical directorship of brain injury unit, or any general rehab unit that has a heavy population of neuro patients, most often they want a brain injury board certified person. But you can want to go to this fellowship and then do private practice. You will make a lot more money if you go into private practice. If those of us that have gone on this path and have board certified and gone into these programs aren't necessarily in it for the money. There's a little bit more attached to it, but you're in it for a different reason, and that's to teach, to progress in research, or to be in a part of a big facility. Once you get into private practice, the caliber of brain injury patients go way lower. You won't take care of disorders of consciousness. You won't take care of the big, bad, severe injuries. They'll go to the big institutions. But after you finish, once you have that certification under your name, you're looking at anywhere from like $250 to $300 starting salary. And then depending on what else you do, or how much you bonus, you'll grow that salary. And then say I'm the program director, right? So I get a part of my salary bought out just to do that job. And so anything that I perform, RVU based over that, I gain more money. So even if you want a lifestyle of an academic facility, and to be part of that camaraderie, you still can make quite a bit of money. And not a lot of people that go through this much school and training and then fellowship tend to go on into private practice. If you have that vision for your life, just go and don't board certify and make your money. But most academic institutions, just like Drew alluded to earlier, the benefits are unbelievable. And now that I've worked in both worlds, you will never beat some of the benefits that I've seen at UK, and a lot of academic institutions probably are the same. But with regard to retirement benefits, disability benefits, my insurance is completely free. It's kind of crazy, actually, what that looks like on the back end, that you're not having to flood your big salary into for retirement. It's already being matched quite a bit as you go along.
Yeah, I think everybody, it's hard. Nobody's really transparent with salaries. And so it's hard to always find that data, especially as students, because we don't get access to, and residents access to those databases that kind of show what the averages are. And so it's always great to hear from people in the field kind of what the averages can be, because then it allows people to guide decisions. And like you said, if you're getting into academic medicine and doing all of that, you're probably not necessarily in it all for the money anyways, although it's very nice to have a secure income for sure.
Yeah, I mean, it's not bad money either way. It's not a million like some people make probably, but it's not bad money. And then you still get to feel like you're making a big impact, which was more important to me. You have to figure out what fits what you need in life. Everybody's a little different.
Sure. So as we kind of conclude and wind down here, obviously after fellowship is over, we've signed that first contract. We're now living in the brain injury medicine world and seeing the improvements and the innovations that come with that. And so where do you kind of foresee the future of brain injury heading? So if we're in 2035, where do you think that we're reflecting on if we were sitting here and saying, hey, remember when, I sat down with Drew and we were talking about the future of brain injury medicine? What do you think has happened over these last 10 years? And I'll use this to kind of plug the UK has the Spinal Cord and Brain Injury Research Center, which I know one of their big focuses is on neuronal regeneration with gene therapies and advanced control systems for functional neuromuscular stimulation, among a whole variety of other things. But what are you most excited about in terms of the future of the field?
Well, I'll be a lot closer to retirement. That was the first thought that came out of my head. Not that much closer, but it'll be.
You've only been out for like 6 years now, so you still got a little while.
I'm already looking forward to it, and I'm really surprised you didn't throw out the plug for Louisville there. But there's a lot of research going around in Kentucky. But if you're landing in these big facilities, you're going to have opportunity to be a part of the big wave that's happening right now. The smarter that we get, period, the cooler our research gets. So I personally delve into a lot of virtual reality stuff that we're doing with rehab, and in association with the neurosurgery and neurology department at UK. There are also gene therapies going on, stem cell therapies going on. And then we're even looking at not only the transcranial stem, but also brain implants to continue that kind of stimulation a little bit more permanently than just in the therapy chair. You've seen probably the external skeletons that are getting nicer and smaller and more realistic by the minute. The first one that came out, you were like, you would never be able to walk with that or live a life that would be meaningful wearing that much metal. But they're getting smaller and cooler by the minute. So that's coming to where people that couldn't walk are again, and stuff like that. So it really just depends on the caliber of brain injury at the institution that you're working with. And that kind of leads you to say, what can we do with these patients for research? But, OMM is making a big run in the brain injury world. And we were stopped for a while just because you can't consent those patients a lot of times, right? But there is a big place for what we do specifically as DOs that will be up and coming. So you'll see in 2035 that is much more utilized in the brain injury world than just in our general rehab patients.
That's great to hear. And obviously we both bleed orange. That's known. So football is always on our mind. And for me with football, we hear about CTE and all these biomarkers that they're working on. Do you see that as a actual reality of being able to, rapidly diagnose a true brain injury versus just a regular, I know concussions are still considered brain injuries, but, being able to do those sideline diagnoses that we're hearing about a lot now?
Yeah, absolutely. We see a huge population of concussion patients at UK. But then they're also looking into a rapid lab analysis of some of those biomarkers as to how they can implement that into the screening process. I see a lot of CTE patients, but right now it's mostly from history and by, deficits in the stepwise pattern. So it's definitely coming, and it's a lot of fun because while I always frown on all of you all wanting to do sports medicine, I love sports. Love them. I always wanted to spectate way more than I ever wanted to work the sideline, but it's cool that I can dabble in that world a little bit and not say that I'm part of it, so I can keep making fun of all you all.
Well, I'm not on the sports track, but I will say it's a great time to be a Vols baseball fan, and we'll just leave it at that. So as we kind of wrap up here, I'm going to be your hype man a little bit because I'm interested in hearing about your own reflections on your career. So, we talked about you graduating from UK PM&R in 2016. So 6 years, not even 6 years yet, technically, because the end of June would be 6 years. But
feels like a lot more.
So, in the last 6 years, you've not only managed to dabble in the private practice world, but you've become a program director. You've been able to start this fellowship program, all while balancing your other career interests like the DEI initiatives that you've started at UK, the wellness, like we were talking about before we started recording, you were the wellness chair for UK PM&R before you stepped down after this fellowship program came to fruition. So all of these things, and obviously on top of your own obligations of being a mom and everything that comes along with that. So for those who look at your career in such a short amount of time and are really blown away by it, like I am, what advice would you have to those looking to either follow in your footsteps or even just step off and carve a path of their own? How reflecting back.
Yeah, I mean, it's pretty remarkable how my life has evolved over the last few years, just because I'm not a gunner. I am a gunner, but I'm not a gunner in the way that some of you all are these days. I never really thought about being all these things as they came to light, but I always wanted to be better than I was the day before. And if you've worked with me or you've heard my lectures, I'm always saying that. Always find the better version of yourself and chase it, and always have goals to improve yourself. And so that's how I live my life. It has nothing to do with being a physician or being in this department. It's just how I live on a regular basis. But you never know what one yes to a simple ask is going to turn into, because that's how it started here. Right? I came back to the brain injury unit. I became the PD. While I was working, while I'm learning to be the PD, I'm working on the fellowship. I just happened to land in the DE&I role, and we created the wellness committee out of thin air, and it has absolutely blown up to the point where I had to give it away to somebody else because I couldn't manage everything, and that person's going to do a way better job than me, I promise. But you just never know how things are going to evolve, and becoming part of the DE&I committee here and then the ambassador at UK has been one of the biggest blessings I will ever be able to describe, and a direction that I always see my career going. It'll be a part of what I do no matter what the rest of me evolves into. But everything I've attained at UK has been part of the in motion momentum that I started with, and it's still there. I can feel it, and I think everybody around us can feel that momentum here. I'm hoping that all programs have a sense of that. But it's ongoing. I never thought I would be the PD, but I was doing that job before I ever got the title. Same with wellness and DE&I. And so I just have to believe that the opportunities will continue to unfold in that way. But if you do something long enough and with the right passion, you'll pave a road that you eventually have no choice but to name. And so we hope that we keep being innovative in what we're driving to do, and stay on the forefront of things too. But I will plug in the wellness piece, and I can't say enough that you can't say yes all the time, because you will get overwhelmed and burn out. It's been proven and proven again. Every article, every other article that comes out these days is about physician burnout, and it's real. So you have to protect yourself. You have to have a good balance of wellness and decompression so that you have the ability to think and create and innovate. Because when I'm busy at work and I'm busy here with the residency, or I'm busy with one thing or another, or I'm on service and trying to do all the other hats, my creativity dies down a little bit, and I see it every single time. And it's part of the cycle. It's supposed to be that way, right? But you have to give yourself the space to create in your minds, or you're going to lose that piece. But I don't have any intentions of this being my own journey. But each career goal that I have for myself will probably flood more and more opportunities in for the residents, the students, and our community, and the specialty in general. If you know anything about me, I've always had a passion for charity in our patient population, but that goes much further than our patient population. I think that's a direction that I'll be headed in, but it will only help our program, have more opportunities to dive into that and give back in a different way.
Well, I certainly can't wait to see how your career continues to evolve and the new hats that you find along the way. And hopefully 2035, you're still out there making your patients' lives better and helping the residents along the way.
So derby styled, flowery, glittery hats is what
yes.
Next. Enough of these black and white, lots of tape kinds.
Yeah, I love it. I love it. Any last plugs? Where can people find you at? I know you're on Twitter and whatnot.
I'm on Twitter. I don't even know what it is. It's like at Jamie Key Yep. My email address though is jamie.key@uky.edu. I started to spell it like I was given a prescription. but I'm an open door policy as far as you all are concerned. I love to hear from everybody. I love to get to know you all on a more personal level, even if you don't come here for training. Drew's going to be down the road, and I can't be happier that he's nearby and that we know each other so well. So if you ever have interest in this regard or don't even know and you want to know more or just be placed with people that can guide you, do not hesitate to reach out.
Thank you again. I appreciate that. And for all of you, thank you for joining us today. Our next session is going to be with Dr. Stephen Kirschblum for spinal cord injury at Kessler/Rutgers University. We're excited for that conversation. In the meantime, if you are not already following us, follow us at AOC PM&R on Twitter, also at AOC PM&R on Instagram. And we look forward to seeing you again. So thank you very much and have a great day.